problem just few months ago. Okay. Anyway, your background is real or is a picture?
Sorry? Oh, no. This is a fake. This is a fake.
Okay.
It is very cold right now. You know, this morning we had 0 degrees in my city.
Really?
Yes, 0 degrees.
Unbelievable. You are in Brazil with 0 degree.
Yeah, we had 0 degrees. We have frost in the morning, so it was beautiful.
Okay. And what about your great barbecue? Is it working?
The barbecue pit is right on the left side here.
Okay.
The barbecue pit is right on the left. The same you visited. Hopefully we get you back here for a second round.
Yes. In every case, I officially invite you for try to test my what I can do in my barbecue. It's not like you.
Yes.
You are.
I know. I should pay as soon as Italy allows people with the Chinese vaccine into their territories. I promise I'll go there and visit you.
Okay. Perfect. Anyway, I'm ready to start if you want.
Okay, I'll mute and turn off my camera, and I'll stay for a few minutes only. Okay, so very nice to see you.
My best regards.
Marco, vamos começar?
Okay.
Marco,
Sorry.
let's go to
I'm
start.
here.
Let's go to start. Can you hear me?
You are live in YouTube now. Thank you, Emiliano, for presentation too. Thank you, Osvaldo, and thank you, Dr. Claudio Lamartina. It's an honor to hear to speak your experience today. Unhappily, this time is not so good because many persons is into operation room at time. But this classroom will be recording YouTube and to other to view. You share your screen.
Can I talk, Marco? Can you hear me, Marco? Can you hear me? Can you hear me?
Yes.
Yes?
Yes.
Yes?
Dr.
Okay.
Claudio?
Yes.
Yes.
If I want to, I can start. When you are ready, I can start.
Okay. I'd like to introduce one of the best spine surgeons in the world. He has over 100 scientific publications in all journal books in Europe and US, Professor Dr. Claudio Lamartina. He works in Milan, Institute Orthopedic Galeazzi. Today, he teaches us how we have to approach spondylolisthesis, making us to learn how to use Lamartine square, including or not L4 in the arthrodesis. Professor Lamartine, can you teach us, please?
Thank you. Thank you very much for inviting me in this chatting, because I hope we can share my experience in this topic with you. Can you see my screen? Can you see my slides? Okay. May I ask you to interrupt me when you want, in every time? Just because the best is to discuss about my idea about this very interesting topic. This is my disclosure, but I think is not relevant for this topic. I want to start just with this example. This is a lady suffering with severe back pain and leg pain without any significant result from conservative treatment. You can see in this upright standing X-ray that there is a more or less second degree in the Myers classification because of L5 slippage. You see that the direction of the sacrum is close to be horizontal. That means there is a significant pelvis anteversion. Here you see that if you compare the standing image with a supine image, you see that there is a significant instability, because now you see we have more or less 20% of slippage, in standing more or less 50%, or that means there is a significant instability. This is the result of the surgery. You see that the surgeon put 4 screws, 2 in S1, 2 in L5. He put also a cage in L5 S1. He had this kind of follow-up. At 1 year follow-up, you see that there is both breakage in S1 screws. Obviously, we can try to explain why this happened. But anyway, I like to focus that there is no more slippage. There is a L5 S1 kyphosis, and there is a rod breakage. The patient was painful. This is the reason why the surgeon decided to reoperate the patient, extending the instrumentation above and below L5 S1. You see that he tried to extend caudally the instrumentation involving the iliac bone, and also extending cranially, including L4. It was impossible to remove one screw in S1, but this is the result. A few months later, you see that once again a disaster. There is one more implant failure caudally. But once again, if you pay attention, there is no more slippage. L5 S1 remain in kyphosis, but because of the rod breakage, the screw breakage, the patient was painful. I asked to be reoperated. You can see that the screw are not an ideal position, especially in L4. In L5, one screw is there is a mobilization of one screw. We were involved in this case at that stage. We had to consider a triple approach. First posterior with the complete removal, then anterior for removal of the cage in L5 S1, implanting 2 large cages in L4, L5 S1, and finally, once again, posteriorly with the L4 S1 posterior instrumentation. Here you can see the intra-op picture. We were it was possible to remove the pliff cage in L5 S1. We put two large cage in L4, L5 and L5 S1. This is the final result with the posterior instrumentation. This is very important just because we have to realize, we have to focus that even if this is a problem at only one level, very often this kind of problem is underestimated by the surgeon, and the result very often is a disaster. But one more example. Once again, is a case of more or less 50% of slippage without significant dysplasia. This was the result of the first surgery with a posterior instrumentation, a partial reduction of the slippage, no cage in L5S1. At 1 year follow-up, once again, a complete implant failure. You can see that now there is a huge pelvic retroversion compensating the kyphosis in L5S1. But in supine image, you see that there is a significant reduction of the kyphosis, a significant reduction of the slippage. That means this area, L5S1, is very unstable. This is the result of the last surgery with an ALIF with a cage, an orthotic cage with 4 screws for stabilizing the cage, plus a posterior instrumentation in L5 and S1. One more example is more or less the same kind of problem. You see that once again there was more or less the same kind of failure. It is the result of the last surgery. Once again, for screw in correct position, a very large screw recreating a lordosis at that level. Two similar cases with the same destiny at the final result, with a definitive result. What we have to pay attention is that we can try to classify the spondylolisthesis, pay attention about the slippage. This was proposed by Meyerding in 1932 with his very famous classification. Until now, the last majority of the radiologist or the surgeon classify the slippage according with the Meyerding classification. On the right, you can see how Meyerding at that time proposed to treat this kind of problem. But the key point remains, he classified the slippage. Obviously, this is a sort of a very strong element for inducing everybody to consider the slippage the most important element, the most important factor in spondylolisthesis. Actually, in 1976, Wilse realized that we have to include in spondylolisthesis a family of different conditions in which the only common factor is the slippage. But we can see that we have dysplastic spondylolisthesis with or without break in pars interarticularis. We can have also a slippage because of a fracture, because of trauma. We can have a slippage because of degenerative changes. We can have also slippage because of pathological condition. That means we speak about spondylolisthesis and we put in a sort of salad a very different condition. We have to try to very well focus that is not the same a dysplastic spondylolisthesis and a degenerative L4 spondylolisthesis are two different conditions, two different animals. Anyway, you see that many authors try to classify the spondylolisthesis considering the different etiological aspect of this kind of problem. But in every case, we have to realize that slippage is not the most important factor. What is very important is to try to answer this very crucial question. When is reduction really necessary? Try to, if we try to answer this question, maybe we can better understand what is the spondylolisthesis. Unfortunately, the level of evidence in the literature is low. If you have a look in the paper that we can read, because very often are retrospective, are case series studies with a limited number of cases. Actually, I don't have a trial in this topic. Also, what I believe is the result of my personal experience, is not the result of a prospective randomized study. This is a limit of our knowledge in this specific topic. But I do believe that what we have considered is not only the amount of slippage, that is the most evident factor. What Meyerding very well defined in more than 70 years ago. The point is, if we can see kyphosis in L5 S1 or not. This is the most important point, because we know that if there is kyphosis in L5 S1, as you can see on the right, we have a compensatory mechanism in the spine and the pelvis, in the hip, in the knee. If we have a L5 S1 kyphosis, we have a hyperlordotic lumbar compensatory mechanism plus a hypokyphosis in thoracic area. But in the same time, the kyphosis, even if is at only one level, is compensating by a pelvic retroversion. This put in extreme extension of the hip, and this create a flexion of the knee. Exactly the same that we see when we consider the principle of the sagittal alignment in adult. If, because of degenerative changes, we have a lack of lordosis in lumbar area or a kyphosis in lumbar area, once again, we see the compensatory mechanism in the spine, in this case with a reduction of the thoracic kyphosis, but once again with a huge pelvic retroversion, hip extension of the hip, a flexion of the knee. Exactly the same. That means there is no significant difference in a pediatric patient or in adult or elderly patient in terms of compensatory mechanism. If we have a kyphosis in lumbar area at only one level, L5 S1, as we can see in the girl on the left, we will have pelvic retroversion, hypokyphosis in thoracic area, a flexion of the knee because of the extension of the hips, exactly the same that we can see if we have a global lumbar kyphosis, as you can see in the right. That means the rule of the sagittal alignment is working in the same in a pediatric subject or in adult subject. If we have a lack of lordosis or kyphosis globally in lumbar area or at only one level, our body responds creating a compensatory mechanism, the same compensatory mechanism. But I believe that you are realizing that the key point is not the slippage. The key point is the kyphosis in L5 S1. This is a very, very important because Jean de Bousset, many years ago in 1997, proposed is a treatment in spondylolisthesis in adolescents basing on the lumbar sacral angle. The lumbar sacral angle is an angle that we can easily measure for L5 S1 lordosis or kyphosis. The problem is that, especially in this plastic case, the L5 S1 end plate is not flat, is a dome. In this case, it's not so easy draw a line for measuring the L5S1 angle. This is the reason why Jean de Bousset proposed this lumbar sacral angle, but it is exactly the same. It's a measure of the L5S1 lordosis or kyphosis. He realized that the cutoff is 90 degrees. If this angle is less than 90 degrees, that means we have kyphosis in L5S1. In this case, reduction is necessary because we have to reduce the kyphosis at that level. Vice versa, if a lumbar sacral angle is more than 90 degrees, there is no kyphosis in L5S1, and there is no need of reduction. This is the key point. We can see very well in this example how we can measure the L5S1 lordosis or kyphosis. In this example, you see very well that the L5, the lumbar sacral angle of de Bousset is more than 90 degrees. In this case, there is no need of reduction. This is a real example. Here you see very well. Vice versa, in a case like this, we can try to measure L5S1 angle, but there is a significant problem for measuring the line in S1 because of the dome. Much easier is to measure the lumbar sacral angle. You see that in this specific case, the angle is significantly less than 90 degrees. Like in this example, you see that is 70 degrees. It is the case in which Jean de Bousset suggested to reduce not only the slippage, but mainly the kyphosis. And at that time, he proposed to reduce this angle with a cast. You see that a very large cast. You see that the patient was invited to remain in prone position in the bed. This is a very uncomfortable way to treat this big problem, but the principle is clear, is evident. We have a kyphosis before the surgery. We have to reduce the kyphosis, not the slippage, but the kyphosis. And then we have to fuse L5 S1 or L4 L5 S1 in also without any instrumentation. We have to fuse L5 in lordosis, as you can see here. But actually, Scaglietti proposed before Jean Dubusse exactly the same kind of treatment in which you see that the patient was in the wrist table frame just in order to reduce the kyphosis in L5S1 with this kind of localizer cast. And then he proposed to fuse in the L5S1 level with an anterior approach. Actually, there is a very strong, a very interesting clinical significance of lumbar kyphosis in adolescent spondylolisthesis, as demonstrated in this very nice paper. But in 2007, the group of Russo-Lee proposed a new classification. But once again, the key point remains to try to know if reduction is necessary or not. This remains the key point. And for this, they propose to focus if the patient with L5 spondylolisthesis has a balance or retroverted pelvis. The pelvic retroversion is a compensatory mechanism of L5S1 kyphosis. That means if there is no L5S1 kyphosis, there is no pelvic retroversion. And vice versa, we see pelvic retroversion. But once again, it remain the same concept. But what we have to know also is the effect of the soft tissue of our reduction. This is only a model, obviously. In this case, we create a slippage, not a kyphosis in L5S1. But anyway, you can do this with an osteotomy. You can put screw in L5 and S1, eventually also in L4. You can create a lysis in the pars interarticularis. You can perform a discectomy in L5 S1, and you can create a slippage. You see that on the left, the slippage is a slippage without kyphosis. But anyway, for demonstrating the effect of our reduction maneuver on the soft tissue, especially on L5 root, this is a good model. Here you can see the difference before and after the reduction. What is the most important point? What's the effect of the reduction of on L5 root? You see that when you reduce the slippage, we have 14 millimeter of translation of L5 root. This is a very important, especially if you have the slippage, but also a kyphosis. In this way, when you reduce kyphosis and the slippage, you have to consider that there is a close to 2 centimeters of translation of the L5 root. But not only our reduction maneuver effect in the nerve, but look at this example, before and after the surgery. This is obviously an MRI. You see that after the surgery, there is an hematoma in both psoas muscle. That means when we reduce, very often we stretch not only the nerve, but also the muscle. This is the reason why every kind of reduction maneuver must be carefully evaluated, must be very well done. In 2011, the same group of Russoli proposed this kind of classification, a treatment-oriented classification, oriented for the reduction. They suggest that we have to reduce the reduction is indicated in case of retroverted pelvis. But actually it's exactly the same what said many years ago Jean de Bousset, with a significant simple classification. The key is kyphosis in L5 S1. That's it. If we have kyphosis, we have a retroverted pelvis. But the retroversion of the pelvis is not the cause, is the effect of the kyphosis. That means a reduction is necessary when we have a kyphosis. This is the point. Without kyphosis, it is not necessary to reduce. Consider, for instance, the case of spondyloptosis according with the Gaines classification. This is a case of type 2 of Gaines classification because below the horizontal line you can see L4 and L5. This is a severe condition that you can treat in fusing L5 and S1 after an appropriate reduction, not specifically of the slippage, but the kyphosis. You can see in L5 S1 there is now lordosis, not kyphosis as before the surgery. You see that for performing this kind of surgery is not necessary to include L4. I want to show you step by step how we can achieve this kind of reduction, the reduction of L5S1 kyphosis. This is an example, but you can see step by step how we can achieve this kind of result. When you put your patient in a prone position, you increase the extension of the hips, you see that we have a small but significant reduction of L5S1 kyphosis. After this, when you put 4 screw, 2 in L5 bicortical, 2 in S1 bicortical, really convergent, you connect this 4 screw with the 2 rods, you have a system of reduction with, for instance, in this case, with this kind of special dedicated shunt screw, you can really reduce the kyphosis in L5S1. I like to show you how you can achieve this kind of result. You see that step by step, we reduce the slippage, there is no doubt, but also we reduce the kyphosis. When you perform a discectomy, you can implement the reduction, but what is really interesting, when you put 2 PLIF cage in this specific example, you can put in compression the posterior instrumentation. In this way, you see that we create lordosis. You see also that the pelvic retroversion is reducing, but the pelvic retroversion is because of kyphosis in L5S1. Here, I think it is very, very interesting. Obviously, it is not always possible to have this kind of very nice result. Sometimes, for many reasons, because you are wrong, or because of the quality of the bone is not perfect, because of the stiffness of the the condition for many reasons. You can try to reduce the kyphosis in L5 S1 as I showed you before, but you can have very early failure, as you can see in this case, in which there is a complete failure of the instrumentation. In this case, you can repair your surgery, extending cranially and caudally your instrumentation. In this case, the Jackson technique is very useful because it's not necessary to fuse the sacroiliac joint. You can use this long special rods that you put in sacral wind. You can create kyphosis, lordosis, sorry, in L5 S1, but you can also reinforce the instrumentation caudally with this special rod, a cranary with 2 extra screw in L4. This is, I think, a good example for showing that it's possible to repair the early failure of your instrumentation using this kind of technique. You can see the final result. You can see that there is a very nice L4 S1 lordosis. How important is the slippage? The slippage actually is not really important. In fact, also the Russoli group suggests to fuse an in situ fusion in case of a balanced pelvis. This is a good example. You see that this lady has more or less 50% of slippage, more or less, maybe in standing more than 50%. That means it's a grade 3 of Mayer classification. But if you try to measure, if you try to evaluate if there is or not pelvic retroversion, you can realize that there is no significant pelvic retroversion. That means there is a balanced pelvis according with the Russoli classification, but also according with Jean Dubusset, the lumbar sacral angle is more than 90 degrees. In this case, an in situ fusion is enough for achieving a stable, good result. In this example, with a modified Grob technique. The rod is implanting just in order to avoid any kind of mobilization of the screw, because the screw are convergent. The rod creates a sort of triangle. You achieve a very strong stability just because of the geometry. This is one more example, but more or less with the same principle. There is no need of reduction in this case, but the construct is a little bit different. But the key point remains the same. No need of reduction because there is no kyphosis. And the last point is when L4 have to be included in our fusion area. Let me show you this very interesting case. She is 11. She suffers from severe back pain. This is the standing X-ray. You see that there is a kyphosis in L5 S1. There is obviously a slippage. There is a significant instability. You see the MRI. If you try to evaluate the pelvic tilt, you have a problem because the DOM in S1 end plate. Much better is the lumbar sacral angle according with the Dubusse. You see that this angle is significantly less than 90 degrees. That means reduction is necessary. Reduction mainly of the kyphosis, obviously. But if you want to reduce the kyphosis, you have to reduce also the slippage. Here you see on the right a complete reduction of the kyphosis, and also a reduction of the slippage. This is the immediate post-op with a significant improvement. But if you look at the 4-month follow-up, if you pay attention in L4, L5, that you see that is in kyphosis, a 2-year follow-up, L4 is also not only in kyphosis, but also is sleeping. There is a severe instability in L4. The patient was symptomatic. This is the reason why I reoperated the patient, including L4. But I want to focus this very easy, simple mechanics in L5 S1. In L5 S1, in every case, in case of spondylolisthesis, but also in every subject, we have a torque. The torque is the result of these two opposing forces, the gravity line and the control reaction coming from the floor. The distance between these two forces is relevant because if this distance is very low, there is no significant torque, and there is no stress in that area. That means there is no progression, and there is no risk of failure. Totally different if you consider the case in which we have kyphosis in L5 S1, the case in which we have a pelvic retroversion. In this case, the distance between these two opposite forces are huge, are relevant. This is the reason why in this case, we see very often, close to every time, a progression of the deformity. This kind of evaluation was very well studied and published by Vidal and Marni in 1983. Based on this, I developed a system just in order to evaluate the unstable area in high dysplastic spondylolisthesis. That means in case of L5 S1 kyphosis. I propose a very simple way for measuring the torque. You have to put an horizontal line from S2. This give us the chance to create this very simple formula that I call severity index. You have to consider the BC, the distance between the two opposing forces. Also, AC is the distance between the ground reaction force and the center of S2. You can measure this. According with the study of Vidal Marne, we know that in normal subject or in case of stable spondylolisthesis, that means spondylolisthesis without kyphosis, the amount of severity index is less than 20%. You can measure this in not only in L4, but also not only in L5, but also in L4 or in L3. Doing this, you can measure the torque. you have to remember that the cutoff is 20%. This is the result of a very interesting classical study, the study of Vidal and Marne. In this way, you can draw a square. The side of the square is the distance between the two opposing forces. You can see inside this square the unstable area. In this specific example, you see that in the unstable area, we have to include also L4. Let me show you the case that I presented just before this, the concept related to the torque. If we try to measure the severity index, that means the torque in L5, also in L4, we see that in L4, the torque is 38%. That means significantly more than 20%. That means the square includes both L4 and L5. This is crucial. This is very important because you can measure this before the surgery. And before the surgery, you can see if it's necessary or not include L4 in your surgery. This is a very interesting case that my friend Marco Cassini gave me many years ago, but you can see that if you try to draw the square includes L4 and L5. This is the case in which you have to fuse, to include in instrumented area also L4. This is one more example. Once again, the severity index in L4 is more than 20%. The square obviously include L4 and L5, and you have to include in your fusion area also L4. In this case, the reduction maneuver are different because you can create this kind of bridge, and then using the reduction screw, you can appropriately slowly reduce the slippage and the kyphosis. Vice versa, in this case, the square include only L5, sorry. In this case, there is no need to include L4. One more example, once again, the torque in L4 is close to be normal. You see that the result of the reduction of the kyphosis is close to be perfect. L4 remains stable. In conclusion, reduction is indicated if the lumbar sacral angle is less than 90 degrees, especially in pediatric patient. This is the classification of Dubuisset. He actually created only two groups, one with kyphosis and one without kyphosis in L5 S1. And L4 has to be included in the fusion if it is in unstable area. And you can define the unstable area drawing the square or measuring vertebra per vertebra the severity index. Thank you for your attention.
Thank you, Dr. Claudio. Francisco.
Wonderful presentation. Yes, wonderful presentation that I've been seeing in the last year. I think so. Just your complete approach of the spondylolisthesis. My congratulations, Professor Lamartine. But I'd like to ask you one question. Is about of the when you went to decide to use a leaf, every time you need to release L5 S1 be a posterior approach, or can you use a leaf in retroversion without to release the L5 S1, but it's necessary every time thought to use a release in L5 S1 before of a leaf or not?
I think it's necessary. I think that you have first to approach posteriorly the spine. You have to perform a reduction of the kyphosis. And doing this, you can approach in very easy way your patient for the Aleph, because without the reduction of L5 S1 kyphosis, it's impossible to implant a cage. If you remember that the case that I show you, the direction of L5 S1 is close to be vertical. That means even if you put your patient in supine, even if you put in extension the lumbar area, it's impossible to approach L5S1 without a posterior reduction of the kyphosis because of the pubis. There is no other direction. Mm-hmm. This is the reason why I do believe you have to first reduce the kyphosis, and then you can put an Aleph cage.
Wonderful. I'd like that audience asked for Professor Lamartine every questions by yourselves. If someone wants to talk, please can ask him the questions.
Emiliano, do you have a question?
Yes. Claudio.
Yeah.
Thank you again for sharing your time. Do you have some use for transdiscal screws? Or do you see them as an option in high-grade slippages in adults with low discs at L5S1?
Yes, especially in adult, it's a good option. There are different tools, a device for doing this kind of surgery, but the principle remains the same. You can do this when you want to perform a sort of in situ fusion, or in case of you have to reduce the kyphosis. Obviously, you have to reduce the kyphosis with the pedicular screw, and then you can stabilize L5S1 in lordosis with this kind of device. But the principle remains the same. We have different tools in our hand. What I do believe is the principle. The principle is in case of kyphosis, we have to reduce the kyphosis. After the reduction of kyphosis, we have to stabilize the result. You can do this with Aleph, with a PLIF, with a PLIF, or also with this large transdiscal vertebral body tools.
Professor Lamartine, what I am observing in your presentations is that when there is some retroversions of the compensations, every time the torque is the torque between femur and spine is very high. Can I say that every time when there is a great retroversions, you have to stop in the L4, or sometimes it's not necessary?
No. It is necessary only if the torque in L5 is more than 20% if you measure with the severity index. Or if you want, if you love the geometry, you can draw the square. The side of the square is the distance between the two opposite forces.
Mhm.
But it's not always necessary.
Okay.
I don't have an exactly statistic in this, but I believe that in 65%, maybe in 70% of the case, is not necessary to include L4.
Thank you
But
so much.
it is just, it's not science. It is what I feel,
Mhm.
not science.
Someone want question, another questions for the professor?
Bruno, any question or any comment?
I'd like to ask you another questions, Professor. When you decide to do a reduction, this reduction, there is two way to do. One is translate of the L5, and the other one is to translate L5 and pushing the sacral against of the L5. What do you think about that? This idea is not mine, by Lewek.
This is a great idea. It's much easier to push the sacrum than to attract L5. There is no doubt, because if you push, you can, the risk of failure is zero. If you have to do something like this, there is a significant risk of failure. This is the reason why I'm developing, but until now is not ready, a system that reduces the kyphosis without traction in L5 screws, but only pushing the S1 screw.
Okay, wonderful.
We are creating a prototype of this sort of leverage, but until now I'm not ready for showing you how this kind of instrument can work. But the idea of Lewek is a great idea. There is no doubt. And this is what I do during the reduction maneuver manually. And also increasing the breakage of the surgical bed.
Using chance screws?
Chance screw remain the best for manipulating the screw, obviously, because it is a perfect extension of your screw. Any kind of extension is not so efficient than the chance screw. This is obviously because of the leverage. But in theory, nothing is strictly necessary. You are totally free to create any kind of system for reducing, for treating this problem. But the key point is you want to reduce the kyphosis. Any kind of instrument is useful, but please pay attention. You have to reduce the kyphosis.
Yes, yes, yes.
This is
Wonderful, wonderful. This principal lesson.
Professor, good morning. It was a good presentation. It's best I ever seen in a few last days. But I would like to ask you, our major fear in this kind of maneuver is the neurological injury. How is your your rate in this kind of maneuver in terms of neurological injury?
There is a very nice study, a study published maybe 20 or more years ago. I don't remember very well. The first author was Sasso. He demonstrated that the main risk of root L5 root lesion is in the last part of the reduction, not in the first part. That means, let me simplify. If you have to reduce 100, the first 50 is zero risk for L5 root. The risk is increasing in the last 50% of reduction. This is the reason why I suggest to reduce more or less the 50% of kyphosis and slippage without opening the canal. In this way, you reduce the risk of dura tear during the reduction maneuver. My suggestion is put the screw, start with the reduction. You can, without significant risk, reduce more or less 50% of your needs. After this, you have to stop your reduction maneuver. You have to open the canal. You have a very well identified S1, but S1 is not our problem. But you have to pay a lot of attention in dissecting L5 roots. Not only in the canal, but also in the foramina, just in order to feel the tension of the root. At that point, under the control of your eyes, under the control of your finger with a gentle instrument, you can feel the effect of your reduction maneuver in the tension of the root. This is very important. And doing this, plus eventually the EMG intraop monitoring, you can reduce significantly any kind of permanent problem in L5 root. Another very important point is if the tension of the root are significant, the best is to avoid to implant plinth cage or cliff cage, because this means one extra manipulation of the root. In this case, my suggestion is to complete the reduction of the kyphosis, or also achieve 80% of the reduction. The last 20% you will achieve with an anterior approach, implanting a lordotic cage. Doing this, even if you have a posterior instrumentation, you can complete your reduction without an extra manipulation of the root. This significantly reduces the risk of L5 lesion.
Perfect. Thank you.
There is another questions or not? Okay. I think so. The Professor Lamartine, it was magnific, wonderful presentations. I think so. The best one that I've seen in my life. It's very nice. You are so detailing everything that you have in doubts. I think it was marvelous presentations. Thank you so much. I expect that for you, because you are one of the best surgeons in the world. Thank you so much.
Thank you very much. It was really a pleasure to spend 1 hour with you. I hope to repeat this in the future. Thank you very much. Thank you.
Thank you.
Thank you, Dr. Claudio. We'll see you later. Thank you.
Bye. Bye. I
Bye-bye.
wish
Thank you.
all the best.